Poštovane dame i gospodo, uvaženi gosti, dozvolite na početku da vam poželim dobrodošlicu na još jedan tematski simpozijum koje organizuje Udruženje kardiovaskularnih hirurga Srbije. Ovog puta govorimo o patologiji luka aorte i torakoabdominalne aorte. Ladies and gentlemen, distinguished guests, allow me to welcome you to this symposium, which is organized by the Serbian Society for Cardiovascular Surgery in collaboration with Livanova Company, for which we are thankful to them. I hope that we will have a fruitful meeting, that we will find some answers to the problems regarding the pathology of the aortic arch and thoracoabdominal aorta. The first session is called Panel Discussion. We will have two presentations, and after the two presentations, we will have a discussion regarding them. First, I would like to ask Professor Lazar Davidovic, head of the Clinic for Vascular Endovascular Surgery of the Clinical Center of Serbia, to present the development of complex aortic surgery. Professor.
Dear colleagues, authorities, distinguished guests, dear Professor Jakub, dear Professor Chiesa, first of all, I would like to thank Serbian Society for Cardiovascular Surgery and especially its President, Professor Kostic, and Secretary General, Dr. Končar, for organizing this event. A few weeks ago in Rome, during this well-known meeting, I had an opportunity to attend one very interesting session dedicated to thoracoabdominal aortic aneurysms. You should agree that aneurysms which involve thoracic and thoracoabdominal aorta as well as the aortic arch are main challenge in cardiovascular surgery, but not only for surgeons and for patients, also for anesthesiologists, I'm sure. Repair of these aneurysms can be performed only in high-volume centers by very educated multidisciplinary team. And today we have really special honor and privilege to meet here two well-known international experts in these fields. Those are Professor Chiesa as well as Professor Jakub. Having said that, I will try to be very brief. Namely, I would like to explain you that complex and risky aortic surgery can be performed with satisfactory results in countries with limited budget for cardiovascular medicine and especially surgery, such as Serbia. Almost 20 years ago, I had an opportunity for one short and unfortunately late education in famous PTS Salpêtrière Hospital in Paris. At that time, Professor Kiefer was a chief of vascular service. You can see that I was younger and slim, but besides myself, many things changed significantly since that time. But let us begin with the beginning. Namely, we started off with routine repair of type 4 of thoracoabdominal aortic aneurysms in 2001. At that time, we insisted on so-called superior excision of the 11th rib to approach distal thoracoabdominal aorta without the opening of the chest cavity. And we performed complete procedure without protection of visceral organs using a well-known Crawford clamp and sew strategy. If clamping time was short and without significant bleeding, majority of our patients survived without paraplegia. Of course, we used routinely cerebrospinal fluid drainage. Professor Kiefer visited Belgrade and Serbia several times. For instance, in 2002, he was inaugurated visiting professor of Belgrade Medical Faculty, and he repaired thoracoabdominal aneurysm in one of our patients. It was very important stimulus for all of us, and since that time we perform routinely all types of degenerative thoracoabdominal aneurysms using partial cardiopulmonary bypass. Of course, repair of type 1 and type 2 of thoracoabdominal aneurysms has been followed with higher incidence of paraplegia occurrence. But at the same time, we had a relative high incidence of acute renal failure that required transient or even permanent hemodialysis. At the same time, acute renal failure increased significantly 30-day mortality. But that was significantly changed when the associated professor Nikola Ilic came back from Maastricht, that he had his education. His education was not also too long, but it was longer than my one 10 years before. Namely, ladies and gentlemen, in nowadays Serbia, it is not easy and simple always to find the money for many different activities and for education. But young people, including, for instance, my daughters, do not understand that problem always. As Don Tommasino said, young people do not respect anything anymore. I'm joking, of course, but not completely. However, thanks to Dr. Ilic, we changed, first of all, our technique of cannulation of the femoral artery. We introduced so-called side arm cannulation through 8 millimeters tube Dacron graft previously placed over the left common femoral artery. In comparison to previous direct cannulation of the femoral artery, that side arm technique significantly, as you know, provides much better preservation of arterial flow in both legs during complete surgery. Thanks to that, serum myoglobin level is significantly reduced, that minimizes its dreadful effect on renal function. From the time to the time, we had the problems with cannulation of femoral vein, but in the past 2 years, we do that using perioperative transesophageal ultrasound assistance without problems. Then, thanks to Dr. Ilic, we have introduced selective retrograde perfusion of visceral organs. In 2012, Professor Michael Jacobs visited our faculty and our clinic. He was also inaugurated a visiting professor of Belgrade Medical Faculty, and during that visit he repaired one post-dissecting aneurysm in our clinic, and it was another very important stimulus for us, and since that time we perform routinely post-dissecting aneurysms. In 2016, thanks to company Livano, the main sponsor of this meeting, we got this new machine for extracorporeal circulation. Because of the conflict of the interest, I will not be able to talk too much about that machine, but allow me to say that machine has some very important advantages in comparison to some others. For instance, it provides much better perioperative distal aortic retrograde perfusion, then better perfusion, selective perfusion of visceral organs, and finally it minimizes postoperative bleeding. In the meantime, we met our first patients that required open surgical conversion after TIVR, but I will talk about that afternoon. We have approximately 1 case of Marfan patient per year that who would be primarily operated because of pathology of ascending aorta or aortic arch, and who would, in the meantime, develop new post-dissecting aneurysm of the thoracic, distal, descendant thoracic, as well as thoracoabdominal aorta. Of course, unfortunately, in only one of our such cases, primarily elephant trunk procedure was performed, and that was certainly helped us during our procedure. Fortunately, cardiac surgeons in Serbia do not perform frozen elephant trunk procedure yet, but I believe that it will be changed after this meeting. First of all, thanks to our distinguished guest, Professor Jakob. Last year, our youngest specialist, Dr. Ivan Tomic, had an opportunity and privilege to be educated by Professor Roberto Chiesa, our another distinguished guest, and his associates. 1 month ago, I believe, Dr. Tomic has finished successfully his exam in vascular surgery, and now he will have the opportunity to show us all significant he learned in San Raffaele. You could have seen developing process of open repair of thoracoabdominal aorta in our clinic. In the past 20 years, we had more than 300 cases, and we managed to improve our results in the past few years. Our experience is included in this meta-analysis published 6 months ago, and of course we are very proud because of that. Of course, our main problem during repair of thoracoabdominal aneurysms is paraplegia. As I already told you, we use routinely cerebrospinal fluid drainage using well-known standard protocols. The next parameters that can be controlled are distal aortic pressure, mean arterial pressure, as well as efficiency of selective retrograde perfusion of visceral organs. Then we perform routinely reattachment of all suitable significant intercostal arteries between TH9 and TH12 levels. Depending of the condition of the thoracic aorta, we perform intercostal reattachment using Karel Eleftheriadis or Wu methods. But, ladies and gentlemen, as you know, all previous procedures are not enough sometimes to prevent spinal cord ischemia occurrence. Unfortunately, we are still unable to check motor evoked potentials routinely. We did it from time to time, but Ministry of the Health promised me that this our problem will be solved until the end of the era, and after that I believe we will improve our early results. What about total endovascular repair of thoracoabdominal aortic aneurysms in Serbia? My father, who is 87, likes to say that the health is the greatest gift and it has no price. But younger generations in Serbia have a little bit different opinion about that subject. Maybe one of the reasons could be a cost of fenestrated and branched stent grafts. These grafts are unacceptable, very expensive for Serbian national healthcare system at the moment. But that is not problem only in Serbia. According to these articles published 6 months ago, the cost of fenestrated and branched stent graft could be also another additional reason for open repair of thoracoabdominal aneurysms, not only in countries with limited budget for vascular medicine, such as Serbia. In patients that were of extremely high risk for complete open repair of thoracoabdominal aneurysms, in the past few years we performed successfully hybrid procedures, including visceral as well as proximal debranching. For instance, this our patient with really extensive post-dissecting aneurysm of thoracoabdominal aorta required both proximal and visceral debranching together with TIVAR. Ladies and gentlemen, I think that complex and risky aortic surgery can be performed with satisfactory results in developing countries, but it requires continuous work by very educated multidisciplinary aortic team. Then it requires continuous education of young professionals, and finally active collaboration with leading international experts. 2 weeks ago, during the last annual Congress of the European Society for Cardiovascular Surgery, Professor Chiesa had a Kiefer lecture, and during it he has included our clinic on the map of European centers that perform open repair of thoracoabdominal aneurysms routinely. That is great honor and privilege for us. Roberto, thank you so much indeed. At the end of this my lecture, allow me to invite all of you to the next ESCVS Congress, which will be held in Padua in Italy in 2020. Thank you so much for your attention.
Thank you, Professor Davidovic, and now I have the honor to ask our distinguished guest, Professor Chiesa, to give his lecture, which is